Thank you very much. I want to thank Will and the organizers for inviting me to speak on drug-induced liver injury diagnostic and treatment challenges. Let's see if I can work this. I don't have any financial conflicts, disclosures, but I will talk about off-label use of N-acetylcysteine. I do have a couple of disclosures that I want to make. One of them is that when I was invited to speak by Will in October, I said, Will, this is supposed to be an AASLD summary, and as you know, I'm covering the service for AASLD. I'm going to be here in San Francisco, not in Boston, taking care of patients. And I said, isn't that kind of like a prepubescent teenager talking about sex? And saying, oh yeah, great, wonderful, very highly recommended. So, you know, I want to tell people that I wasn't at the meeting, but I did read through the syllabus or the abstract book. And unfortunately, many of the papers I didn't think would be relevant or interesting to the group. A lot of basic science, important as it is a long ways from clinical application. I tried to focus on papers that were hopefully helpful, and just a few of them, unfortunately. The other thing I want to confess is, or just as a disclosure, if I nod off during the presentation, somebody come and poke me. I was up most of the night with this is the son I never had, Chadley, and he's been struggling. So yeah, I'm hoping the quad vente latte I just finished helps me you know, present in a comprehensible fashion. So this was just part of the abstracts. Again, I'm only going to do a few that I thought were of relevance to the clinical talk. The outline, we're going to cover several different topics. Causality assessment, how do we make a diagnosis of drug-induced liver injury? It can be challenging. I'm going to talk about acetaminophen, the liver tox reference online, which hopefully many people are using. It's I think, a really wonderful resource. And then several different drugs that cause idiosyncratic drug-induced liver injury, just so you get a flavor. And many people have seen these before, and all the data I purposely took, with the exclusion of mentioning a few abstracts, is from the liver tox website. So really a very useful website when you see these patients and you're thinking about drug-induced liver injury. I'm going to briefly talk about a paper that's been published some time ago about called hepatitis E, masquerading as DILI, and then I was asked to at least talk briefly about DILI from statins, and I'll do that at the end. So causality assessment, I like to use the CSI analogy, and people are familiar with this show. Basically approach it the way they approach a crime. Was the drug in the right place at the right time? And obviously, if a drug was started after patients start having liver injury, that's pretty strong exculpatory evidence. On the other hand, if a drug's been used for more than a year, it's unlikely that that's the culprit. Can it happen? Yes, but it's unusual. It's unusual. And so you have to really try to get that information. Many patients don't know what drugs they take, and I found it useful to contact the pharmacy in those cases to really try to get an accurate drug history. Does the drug have a prior record? So does it have a track record of drug-induced liver injury? Some drugs much more likely, and the ones we'll talk about as examples have pretty high incidence of drug-induced liver injury relative to other drugs that we use. Are the characteristics of the apparent DILI event, the crime, so to speak, consistent with the modus operandi of the implicated drug? So drugs have certain signatures, and that doesn't mean they can't do something different. You know, INH, we'll talk about, has primarily hepatocellular injury, whereas anabolic steroids almost always cholestatic, but there's in between some variation. So you can have different signatures, but it's very helpful if you have a signature of the drug in mind. Are there other explanations, other culprits that could have caused the liver injury event other than drug-induced liver injury? And we call that competing causes. That's why we always have to remember this is a diagnosis really of exclusion. There's no 100% this is drug-induced liver injury, almost never, unless there's a re-challenge, et cetera, which is very, very rare. And then finally, is a clinical course consistent with drug-induced liver injury? Most cases of drug-induced liver injury, as long as they're not too severe, stop the drug, patient gets better. And that's why it's important to think about this. Stop drugs that you can stop in case they're the cause. So think about those different things. The other thing I want to just mention is when patients go to transplant, you never know then whether there was what we call a D-challenge. When the drug is off, do the liver tests improve enough? If patients die or they go to transplant, really you don't have that information. And causality, therefore, is always suspect. So I'm going to talk about acetaminophen. I consider this the elephant in the room because many meetings I used to go to when I was part of the Drug-Induced Liver Injury Network, we'd focus on idiosyncratic drug-induced liver injury and not the only drug really in our quiver that we use with any frequency that's really dose-dependent hepatotoxin, meaning if I give, 30 grams of Tylenol to anyone in this room, very few people are not going to get super sick. No one would, in fact. Everybody would get sick. Most of us would probably die. A few people would survive, but this happens in everybody. So that's why I want to spend some time. And it's also by far the most common cause of drug-induced liver injury. So this just reminds me of some of our DILI meetings. Okay, is there anything about DILI that we haven't covered? And the elephant in the room is APAP. So it's a dose-dependent hepatotoxin, as I said, most common cause of acute liver failure by far in the US. There was some data early on in the ALF study group that it was increasing. My sense is now that it might be falling some, probably from regulatory changes. There's many misconceptions surrounding this. And one of the common ones that when I get called on patients from local ERs calling me about drug-induced, or calling me about liver injury, patient may be encephalopathic or even a coma. They want to transfer for further evaluation, possibly for transplant. I said, well, did you start NAC yet? And often the answer will be, well, the acetaminophen level is 0, so this can't be acetaminophen. And that's wrong. And I'll show you data suggesting that or supporting that. And the other is it's too late to give NAC because the patient already has ALF. And certainly NAC and acetylcysteine is very, very effective. It's really incredibly effective when you give it to patients who have had a large ingestion of acetaminophen before they have liver injury. No one develops, they can take a whole bottle and almost no one will develop. They'll develop liver injury perhaps, but they won't develop a liver failure and die almost without exception. As you wait, hours after the ingestion, if it's an acute ingestion, the risk of complications and the efficacy of the drug worsens. So important to give the drug quickly, and there are data that I'm not going to go into that it's helpful even when patients have ALF. So it's really the standard of care. Let's talk briefly about acetaminophen metabolism. We all know that the drug's a prodrug in the hepatocyte. It undergoes glucuronidation, sulfation to harmless water-soluble conjugates. Below that, about 5% on average is bioactivated by CYP2E1, one of the cytochrome P450s, to a bioactive molecule that's shorthand NAPQI. It's an electrophile and it binds to proteins and peroxidates lipid, causes or initiates the cell death pathway. I'll get back to that in a few moments in terms of diagnosis. Actually, I don't know if this will work backwards. So what we do, I didn't mention, I should, that we give N-acetylcysteine because that binds to either NAC itself or glutathione, which it restores, binds to NAPQI, and again, kind of rescues the cell from injury. It causes a water-soluble metabolite that is excreted. So important to give NAC, which is a 3 peptide molecule, including cysteine that is used to make glutathione. So this was some of the early data, and it really didn't change over time in terms of proportions of the acute liver failure study group. You can see On the far end, ACM is APAP or acetaminophen. It's by far the leading cause of acute liver failure in the US based on these data. Much more common than other drugs, all combined, viral hepatitis, autoimmune, et cetera. The far end of the thing to my, I guess, right side, indeterminate, is actually a fairly large group as well. That's cases where we've done all the testing, all the viral testing, everything we can think of, and there's no etiology, so it's called indeterminate ALF. And again, it's about 15% in adults, much higher in children. And is it surprising that acetaminophen toxicity is so common? I don't think so. This is an older slide that just shows an example of liver pathology from a patient with ALF from acetaminophen poisoning, and surrounded by various products that contain acetaminophen. And these are just the proprietary ones, but we know patients have access to this. Not shown are the acetaminophen opiate combinations that I'll get to in a moment. As I think I mentioned, over time in the ALF study, in the early days, the incidence of, or the prevalence of acetaminophen poisoning in our cohort seemed to be increasing. Again, I think it's leveled off, but is still quite high and by far the leading cause of ALF. Whether this was a real effect or whether we're just becoming better at diagnosing ALF from acetaminophen isn't clear. If you look at the various etiological groups in tabular form, you can see that the APAP group, the acetaminophen group, tends to be young, primarily female, very low percentage of jaundice or days of jaundice compared to the other groups. High incidence of coma, very high ALTs, the highest in the cohort. Again, not very high bilirubins. Transplant is low for two reasons. One, these patients have a high spontaneous survival that's shown. And two, if they're intentional overdoses, they have contraindications potentially. But the overall survival is quite good. You can further break down the acetaminophen group to suicidal or self-harm versus unintentional. And Ann Larson, one of the investigators, did that and really carefully analyzed and compared the different groups, and found that in both groups, females predominated. The amount of acetaminophen ingested, at least in a single day, was much higher, as you might imagine, in the APAP group. Coma was more common, I think, because the patients in the unintentional group were using a combination acetaminophen opiates. I'll get to that in a second. The ALT was slightly lower in that group. The spontaneous survival is the same. Antidepressant use was interestingly the same as well. But the real important thing, I think, is the bottom. Again, acetaminophen opiates, that drugs like Norco, Percocet, and Vicodin were used much more commonly. And these patients typically have chronic pain. They're put on these drugs. They get addicted to the opiate. They require more and more to control their pain. They then have an intercurrent illness. Some of them are taking massive daily doses of acetaminophen. You know, I've had patients taking well over 30 grams, and in the literature, there are patients taking 70 grams of Tylenol with no ill effects as Norco. It's incredible. What happens, though, is they get an intercurrent illness, they stop eating, their glutathione in the liver probably falls to critically low levels, or they take acetaminophen as a cold preparation, et cetera, on top of what they're taking, they end up in liver failure. So I guess one question is, who came up with the idea of mixing a dose-dependent hepatotoxin with a highly addictive drug like an opiate together in a single pill? I'd like to meet that person, because I don't think it was a great idea. In any event, I think now we're all attuned to this problem, and these drugs are prescribed less frequently, people with chronic pain, which is important. When I was at UC many years ago, I was seeing patients over and over again that looked like acetaminophen. They smelled like acetaminophen. They had high aminotransferases, low bilirubin. They probably had a history of chronic pain, but they were in a coma and couldn't give history, or you know, their family and the patient said, no, I don't take anything like that. And they denied acetaminophen. The levels would be negative. So they were put into this group. You know, we had to call them, and all their viral serologies, everything else was negative. They were called indeterminate. But I wondered, were some of these occult acetaminophen? And I wondered, you know, this NAPQI, this electrophile binds to proteins. Might some of the proteins actually get into the serum just like ALT and AST do when we have liver injury. And I looked in the literature, and there's a group in Arkansas, led amongst others by investigator Laura James, and basically she'd been studying this, an adduct assay, looking at the NAPQI protein for a number of years in animal models. She's a pediatric toxicologist and investigator. So we approached her as a part of the ALF study group and asked her, to study this question with her assay. It was an HPLC assay, kind of cumbersome but very accurate. Could she look at our groups and see if this had any diagnostic utility? And the hypothesis was, again, that some of our indeterminate patients were actually occult acetaminophen patients. So she did that. We sent her sera from the following groups. APAP on the far end there. She was blinded to all these, by the way. She identified in all the patients addicts at high levels. Non-APAP controls, Wilson disease, autoimmune hepatitis, viral hepatitis without APAP on board. Those were all negative. So it seemed to be a pretty reliable test. She had a small group of patients who had taken, teenagers who had taken overdoses but presented before they developed liver injury. They got NAC right away. And those patients actually had barely detectable addicts. So and without liver injury, you don't really generate the addicts, and they don't kill hepatocytes and get into the serum, presumably. So it was really almost undetectable. The most important thing in the last two groups, both those groups are indeterminate cases, and a significant portion of patients in the indeterminate group that we were, wringing our hands. What are these patients? Is it metabolic? Is it some other toxin? Turns out almost 20% were occult acetaminophen, at least based on these data, which was somewhat surprising and potentially important. And this has been replicated by subsequent larger studies by the same group as well. So I don't know why this came out different, this picture, but what this is just a K graphs of the addicts. It didn't look like this on my computer. Never has looked like this. But in any event, there's ALT and then the addicts with the in, I think, black, and the other one's in blue. And what you can tell is they kind of follow the same kinetics. And the important thing that, again, you can appreciate by looking at the two bottom graphs is that the addicts are detectable even when patients come in without detectable acetaminophen. The prodrug, gone, but they still have addicts leaching. And they basically continue for about, as long as your aminotransferase are really high, the addicts tend to be high as well. So it's very useful even in late patients. So summarizing at least this part, acetaminophen, most common cause of ALF in the US, increasing incidence perhaps, many misconceptions that we already talked about. Certainly you want to treat patients even when, disregard the acetaminophen level, except in a patient who has an acute ingestion, and then the history is often not accurate. If it's positive, it's helpful. If it's negative, and someone has liver injury, especially if they have any exposure at all to acetaminophen, treat them with NAC because it's life-saving. I won't go into data showing that NAC may have a role in non-acetaminophen poisoning, but another reason to use them as well. That was another publication by the ALF study group. And this quote, NAC is TPA for the liver. We used to use TPA all the time for coronary stenosis, using stroke and whatnot. And time is really, patients get it really quickly. There's just a leisurely approach, I find, to NAC. And it really is the same thing. Like I said, if it's given early, really has much more efficacy. So I've been called by referring physicians say, you know what, I'm going to hang up now. I want you to start the patient on NAC and call me right back. And it kind of irritates people a bit, but it's really important. I've seen patients where it's delayed. They get sent to the floor before they get started. They're given oral NAC, which they vomit up, and they go from a completely salvageable situation to acute liver failure, which is life-threatening. So really can't be overemphasized. It's a very important drug. So ASAP, we always need to be suspicious of acetaminophen, and the levels are unreliable. IV is just more reliable than oral NAC for the reasons I just mentioned. Patients who have cryptogenic ALF and high aminotransferase should be treated with NAC for sure, because some of those patients, many of them are occult acetaminophen. And then late administration. I won't go through the data of that, but it turns out some patients in the NAC study that were supposedly not acetaminophen were actually put in the study and turned out to be acetaminophen. And those that got NAC did much better than those that didn't, although it was a small number of patients. So high-risk groups for acetaminophen, chronic pain, I talked about. Depression's obvious. Prolonged fasting is really important. Alcoholics, we all know about it. It's on the package. Bariatric surgery, I'm going to briefly mention, especially since Will is here, and he may have, I don't know if he talked about this before because I arrived late. He probably didn't because he had other things to talk about, but he was instrumental in these data. He's already gone through the obesity epidemic and the fact that bariatric surgery is becoming more and more popular, quite effective in sustained weight loss. I'm sure he went through data in terms of its role in our NAFLD patients. So the prevalence of bariatric surgery, this was older data, 1.5 million, higher now, increasing incidence over time. Gastric bypass does appear to alter the metabolism of the absorption and metabolism of APAP, and we thought predisposed to a liver injury. These are data from when I first came to CPMC, and Will was actually a very bright, motivated fellow, and took this study and ran with it. We studied 101 consecutive ALF patients presenting to CPMC between the years shown. 54 were APAP, 47 other causes, which kind of matches the national epidemiology. Of the APAP patients, 9 of them had prior bariatric surgery, none of the other patients. So patients with viral hepatitis, Wilson disease, yada, 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 autoimmune hepatitis, none of those patients had prior bariatric surgery, and that was statistically significant as shown. The bariatric surgery group didn't seem to have higher rates of depression, alcohol abuse, or intent for self-harm that we could tell. And after adjusting for age, gender, race, depression, and alcohol use, prior bariatric surgery remained independently associated with acetaminophen ALF with an odds ratio over 10. The prevalence of bariatric surgery in our population with APAP ALF was 16.7%, which is about 25 times higher, 25 times enriched compared to the prevalence in the general population, suggesting that there probably is something going on here. And we felt if these data were confirmed, the label on APAP containing products should include a warning to caution in the setting of prior bariatric surgery, and obviously that already exists for people who drink alcohol. And in our opinion, this is probably a higher risk than your average alcoholic. The ALF study group actually looked at their independent data and confirmed this in an abstract at the AASLD several years ago. That's a picture of Will, by the way. I don't know if you could tell. I could have used him as a picture when I was talking about the prepubescent teenager talking about sex, I guess. He looks really young there. Anyway, let's talk about liver tox quickly. This is a really important, people use this? Have people been using this? Yeah, no, nobody, yes, okay. It's a great thing. This is Hy Zimmerman, a picture of what many consider the godfather of modern hepatotoxicity. And this is a website that I think was inspired by his work and is something that I would definitely recommend that you check out if you have patients with possible drug-induced liver injury. It's a collaboration between the liver branch of the NIDDK that is spearheaded by Jay Hoofnagel, pictured here. This was really his labor of love when I was part of the DILI group and we were approached by the NLM. We all thought it would be way too much work, but Jay went with it. He has a little cadre of medical students that work with him, and a really impressive accomplishment. I think so far it's been the most important thing that Dylan's contributed to, even though it's not a Dylan exclusive effort. It's up to date, it's comprehensive and unbiased information about drug-induced liver injury from prescription, over-the-counter, and CAM agents. And the nice thing about it is you can get in and get out really pretty quickly. It's very stereotyped the way it's organized. I just find it incredibly useful. And it's a living textbook that's regularly updated and improved, thanks to Jay. So let's talk about some drugs and use data from the liver tox. INH hepatotoxicity, call this yellow consumption because consumption is what INH is used for, and patients often turn yellow when they develop liver injury from this. So it's used mostly, as we know, more commonly for latent TB, but also as combination therapy for clinically overt TB. It's a mainstay of therapy. It frequently causes asymptomatic elevations of liver tests in up to 20% of patients, but those don't seem to evolve in many patients. Nonetheless, it's a major cause of severe drug-induced liver injury and even ALF. So if you look at registries of drug-induced liver injury and patients dying and needing a transplant, INH is right near the top. Despite the fact that we won't use it as much as many other drugs. The major risk factor is age. As we know, we don't typically treat patients with a positive PPD over the age of 35 or so. Underlying liver disease, especially Hep B, older reports. I'm not sure I completely believe that, because a lot of the data were from before nucleoside-nucleotide analogs, and we know patients with hepatitis B can flare, but think before you treat these patients, because there are there are a number of case reports and case series suggesting that underlying liver disease, especially from Hep B, may be important. Other drugs, alcohol, rifampin for sure, increase the risk. And then there may be some racial and genetic predisposition as well. The latency, the time from taking the drug to presenting with liver disease is 1 to 6 months in most patients. It's really in the first 3 months that the majority of patients will present. Clinically, it represents, and histologically represents, viral hepatitis. So it's hepatocellular injury, often with jaundice when it's severe. There usually aren't things like rash and fever, although I've seen fever for sure. The ANA may be nonspecific positive, but usually in low titer and a speckled pattern. ALF seems to be more common in the literature and in my experience in women, and especially women who are African-American descent. The reasons for that are not clear, but again, that's been an observation by a number of investigators. The treatment stopped the drug ASAP, and that's why it's really important these patients who are treated with INH get educated. There may be some role for NAC, we use it, but it's not really well studied. Steroids I would not normally recommend. There are some case reports, but I have not done that. Think about transplant early, because the prognosis with this group is not good from personal experience. Remember to think about reactivation of latent TB, because these patients usually get short courses of therapy. So I've seen a couple cases now where therapy was interrupted, patient got transplanted, 2 months later started presenting with fever or other symptoms and had TB in the setting of immunosuppression. So anyway, that's the histology, again, not specific, but disorganized, and looks like viral hepatitis. Augmentin hepatotoxicity. This is a quote from one of my patients. He called an incredibly intense yellow itch. This guy was miserable. He lived in the East Bay, older gentleman that had this problem. It's the most common cause of clinical apparent drug-induced liver injury in both the US and in Europe. So one of the leading causes, probably leading cause in Western countries of drug-induced jaundice. It's the clavulanate, not the amoxicillin. So technically you can treat these patients with amoxicillin after they've had an event, although most people would probably avoid it. Risk factors, age and prolonged course. So the typical patient is an older patient, in my experience, older gentleman who's had bad sinusitis, course of Augmentin, doesn't get better, so he gets another course of Augmentin, long course. And then the interesting thing, the latency is about 3 weeks. Most patients have finished the drug when they present. They're off the drug a week or two. It's kind of ancient history for them. They start developing pruritus, and then the symptoms listed. It's either cholestatic or mixed. Hepatocellular in kids, although this has got to be rare in kids. I'm not a pediatric hepatologist, but kids get this drug all the time for otitis, and there's just not that many case reports of liver injury. There have been some HLA markers that seem to predispose patients. And actually, this is one of the abstracts from the DILI group looking at an enzyme called ERAP2 that apparently trims peptides so they fit into the antigen binding site of HLA protein. So it's kind of related to the things that have already been identified, which are HLA markers. And the polymorphisms in this that should be ERAP2 polymorphisms, are associated with other autoimmune disease, including ankylosing spondylitis and psoriasis. So the DILI group looked at 444 augmentin cases, over 10,000 population controls from Northern Europe, and through a very sophisticated analysis of genetic polymorphisms and genome sequencing, was able to find an association of low ERAP2 with liver expression with AC DILI, suggesting that maybe there's an altered presentation of augmentin-induced neoantigens on liver cells in these patients. Very early work, not ready for diagnostic testing, but certainly an area that could be studied further. Jaundice may be prolonged, and the patient that coined this term, it was well over a year, not quite 2. Pruritus was intense and he was miserable. There have been cases of vanishing bile duct syndrome described, but that's rare. Usually, clearly stop the drug. Most of the time, that's irrelevant. In fact, I've seen patients who are referred for transplant evaluation who kind of fit this, and I ask them, they say, oh, I don't think I was on augmentin, but it turns out when you go to the pharmacy, they were. And it's that classic of a presentation that you can make the diagnosis without even having the history of drug exposure. Urso we use as a non-specific agent in cholestasis, whether it shortens course has been studied. Cholestyramine and other measures for the pruritus. Steroids have been, again, reported, but I wouldn't recommend them as first-line therapy for sure. Nitrofurantoin, hepatotoxicity. This, on the other hand, steroids have a role. It's an autoimmune mimic. It's used for treatment, as we know, of acute and prophylaxis of chronic and recurrent UTIs. There are over 5 million scripts per year. It has several names, so it can be confusing for patients when you ask them if they've been taking the drug. Several significant side effects are associated, and I've seen at least a couple. I've seen interstitial pneumonitis, in patients with liver injury. I haven't seen the others listed here, but they're all well reported, except perhaps the dermatitis. Drug-induced liver injury takes 2 forms. The acute, I've only seen 1 case. It's less common. 1 to 3 weeks of treatment, so a short-term course of hepatocellular injury, fever, and rash. ANA is actually uncommon in that group. The chronic patients, much more common. This is the classic patient. Months to years of therapy. These people have recurrent UTIs. They get placed by the urologist or their primary physician on nitrofurantoin, and they don't have any more UTIs, but they present ultimately with something that looks just like autoimmune hepatitis. Female, gender and age seem to be risk factors. It's often, if not classically, associated with autoimmune markers, so it really does look like autoimmune hepatitis. Treatment is drug withdrawal, and I would base steroid therapy on whether they're sick or not. If they're sick, they definitely should get treated with steroids, but I would recommend trying to taper those with improvement and not instituting steroid sparing agents unless they recur. And most of them don't. This is just the histology. Again, it looks like autoimmune hepatitis. Anabolic steroids, we're coming towards the end. Incredible bulk. This is actually not a name I came up with. This is the name of an actual product. I've seen this 3 times now in young men taking this agent that you can get over the internet. Alkylation of the C17 position of testosterone allows for oral absorption and increased anabolic potency. This is a quote from the liver tox, as is the following. The androgenic steroids are often used off-label and illegally as a means of increasing lean muscle mass and athletic performance. I don't know why. I could just imagine Jay Hoofnagel typing this in kind of, tongue in cheek. He's, I think, an unappreciated comedian. I'll get back to that in a moment. It's found in a number of nutritional supplements and available over the counter and on the internet. And this is data. So I went to the website, I went to the incredible bulk website and found they actually do studies. These were powered by something called MVP Scientific. And these were data from a group of men, presumably 18 to 25, so young men. And you can see that 4%, I think that says no gains 11% gained a bit. This is muscle mass. 40% off awesome gains, and 45% I feel huge. So it's impressive. I also think the way the data are presented, I wish that journals would allow us to present data on like cracked concrete with the corrugated steel background, because I think it makes the data really pop out more than the average journal. So now if we go to a little bit older age group, these are senior citizens, 26 to 32, small number, still about the same, gained a few pounds. Wow, I gained a lot. And then 41%, freaking huge. What exactly is freaking huge? Well, they show you here. And, you know, to me, this seems like it would be a disability. Driving would be difficult. Personal hygiene might be a problem. And, you know, performing liver biopsies with a jam-sheeting needle would be near impossible. So in any event, the people really like to look like that, I guess, because, again, I've seen patients take these over and over again, and this product and others. The drug-induced liver injury, even when they've had liver injury, it's hard to get people to stop sometimes. Drug-induced liver injury secondary to bodybuilding agents like this is something that we observe frequently in the DILI network. The signature phenotype that we observed is bland cholestasis. It's fairly easy to recognize. The jaundice may be profound and long-lasting. I've even seen patients who require dialysis and on kidney biopsy have casts of bilirubin histologically, which is unusual and speaks to the fact that they have a profoundly deep jaundice. ALF is rare. They don't need to be transplanted, but they may need dialysis, like I said. This is a histology from a patient. Again, it's bland cholestasis. Treatment, stop juicing. Unfortunately, athletes and bodybuilders may resist this recommendation. Again, quote from Jay, and I find it to be very true. The patients, again, typically young and middle-aged men, really want to be big. Ursodiol, cholestyramine, sometimes even nasobiliary tube could be considered for profound pruritus and jaundice. No steroids, obviously, no transplant, hemodialysis, as I mentioned. Just a couple other complementary alternative medications. There was a drug called Octiolite Pro, which people may remember caused some cases of ALF beginning in Hawaii and then elsewhere in the country, including Nevada. There was at least one death and several transplants. This is back a number of years. The phenotype was very different than the one I just described, even though this was another product proposed a CAM product for health. The phenotype was hepatocellular injury with jaundice, the mean latency about 60 days, and the agent responsible was identified. The drug was recalled. Another abstract, do people know what kratom is? I've heard of this, but I don't have any real experience. It's apparently a popular CAM product that has opiate-like activity, and it's being abused more and more along with other opiates in the population. It has sedative narcotic effects. There have been 90 deaths reported at least, and there are 7 cases that the DILI network had of drug-induced liver injury, mostly men. Latency was about 22 days. The ALTs weren't very high. It was a mixed picture, and with jaundice, and all patients recovered. This was actually presented, I believe, as an oral abstract, just to get the word out. So if you see young people that, young and old, I guess, that may be exposed to this, think about it. The outcomes were good. Switching gears back to kind of diagnosis, I said that drug-induced liver injury is a diagnosis of exclusion, and it's difficult to exclude everything. There are things we just we can't diagnose, or at least easily, and we haven't even thought of yet. Hepatitis C, when I grew up, was a disease only seen in the US in travelers. So people would go to India and subtropical regions, and after they came back would present with liver injury and jaundice, and that's when we diagnosed it, and that's incredibly rare, but we'd see them occasionally. It never happened. That was the dogma. It never happened in the US. Well, when I was at the Drug-Induced Liver Injury Network, Jose Serrano, one of the NIDDK investigators, and Jay Hoofnagel along with collaborators in different branches of the NIH that, including Bob Purcell, who's a leader in Hep B, thought it would be interesting to look at whether there might be some Hep B cases that were masquerading as DILI in our network. And I, you know, having grown up in a time when that just didn't happen, I thought it was going to be a wasted effort, but it turns out I was wrong. We looked at 300 cases, the first 300 that were enrolled. 50 of the 300, 16% had IgG hepatitis C. That means they were exposed, and that sounds ridiculously high, but actually NHANES data suggests that that's kind of the US population, that there are a lot of patients that have this antibodies, and why isn't entirely clear. More interestingly, 9 had reactivity for IgM, suggesting acute infection, and 4 of the 9 had HEV RNA confirming the diagnosis that these were in fact acute hepatitis, I said hepatitis E cases. Why were only 4 of the 9? Well, these were cases that were often enrolled after we got the SIRA, after the jaundice had resolved. So it's not surprising. If we got, you know, the IgM lasts much longer than the virus, like most, the viral genome, like most viral infections. So if we had a higher percentage, it would have been unusual. Of the 4 that were positive, they're all genotype 3, and that's, it turns out, based on a lot of other data, the genotype that we see both in the US and in other Western countries like Great Britain, elsewhere in Europe, Germany, Japan, elsewhere. And it seems to be that this is a zoonosis. It's a porcine virus primarily, but maybe other animals as well, that ingestion of undercooked meat from pigs and other animals can lead to infection. The epidemiology in our group, it was a small number of patients, but there were 8 men and 1 woman, and the mean age was 65. That was much higher than the rest of the group. So that should be a tip-off that something weird is happening here. This is not your average drug-induced liver injury patient. None of the patients had traveled, so these were not you know, acquired in endemic areas and then brought to the US. So think about Hep B when you see cases of possible DILI, but you don't, you know, they're hepatocellular, but you don't have a good culprit drug, especially in older patients, and often they have comorbidities. Statin, I'll just end with, I think I have 2 minutes left. The reason I have a rabbit here is, first of all, recall these are HMG-CoA reductase inhibitors. Turns out that statins have a bad rap, I think, primarily because they were studied initially as novel drugs in rabbit models, primarily because they're rabbit models like the WHHL rabbit that are very high cholesterols. They're models of familial hypercholesterolemia, and you need a high cholesterol to study a cholesterol-lowering drug. It turns out when you block this enzyme in rabbits, there's very high incidence of the liver just kind of falling apart. That clearly doesn't happen in the US. These are among the most commonly prescribed medicines. There's 7 approved statins that I know of, and all of them have been associated with mild LT elevations, but they typically resolve even with ongoing therapy. That being said, there are cases, rare, especially when you look at the denominator, the number of people treated, of clinical drug-induced liver injury with all 7 drugs. It's almost always hepatocellular, but not always. Sometimes it's mixed. A few case reports. I've seen a few case reports of hepatocellular injury. Variable latency. Again, very unusual. Some cases years out, which makes me suspect. But again, that's what's been reported. Some of them have autoimmune features, so it's possible the drug causes liver injury in a low-grade fashion, and then in the predisposed patient results in a autoimmune-like liver injury. But it's quite uncommon, quite uncommon. As we all know at this time, and I reported in the last meeting and in prior meetings as well, the AASLD, statins seem to have a beneficial effect in the setting of cirrhosis. Will may have talked about some of this as well. There are multiple studies, and almost all of them are retrospective. There's one that I know of that's a prospective study, but it's relatively small. They suggest that statins aren't only safe, but they're beneficial in patients with cirrhosis. So it kind of flips our old preconceptions on its head. There was reduced liver decompensation, development of hepatocellular carcinoma that should see infection and even death in various of these studies. The important thing is that I think Ray pointed out in a number of the studies with beta blocker that were retrospective, really hard to interpret these. There's confounding by indication here. For example, most of these patients were treated because they had high lipids, and patients with really advanced liver disease don't tend to be able to generate the really high cholesterols that we think of with treating with statins. So even though these are controlled in various ways, I think it's really hard to complete in correcting for these confounders. And I think we need better prospective data before we can widely adopt a practice of treating all cirrhotic patients, although it's certainly an area that deserves prospective studies. Again, there's a number of reasons why the statins may be helpful listed there. So just ending with some cardinal rules in a minute left. Always think about drug-induced liver injury in patients with liver injury. So if you have a patient with unexplained liver injury, really interrogate the patient about their use of medications, including herbal products, which are becoming increasingly commonly associated with significant drug-induced liver injury. Always think about acetaminophen poisoning in the appropriate patient who has high aminotransferases, low bilirubin, and particularly if they have risk factors like the ones I mentioned, chronic pain being a big one, also bariatric surgery, as we discussed. Stop the culprit drugs ASAP. I would advocate early and liberal use of NAC, including, again, I mentioned it's been shown to have some efficacy in non-acetaminophen ALF. Early referral for transplant. I didn't talk about the fact that drug-induced liver injury probably has a worse outcome with the same biochemistries compared to a viral hepatitis patient. So these patients in general don't do well when they have deep jaundice, and certainly if they develop coagulopathy. And hepatic encephalopathy, they do terribly without transplant. So thinking about transplant early and referring patients is appropriate. And then I would, again, advocate consulting liver tox early and often, because I think it's a great resource. Thanks.